Good morning, everyone. Myself, Dr. Pankaj, and I'm pediatrician by profession and teacher by passion. Welcome you all in Pedia Academy of Pediatrics. Today, in this amazing series of NEET SS previous year's topic series, we are discussing the important topic of inherited hyperbilirubinemia. This topic is very important as per practice point of view and as well as exam point of view. So, without further delay, let's start this topic. So, we are here like congenital disorders of inherited hyperbilirubinemia. So, as we discussed, inherited hyperbilirubinemia is classified as unconjugated hyperbilirubinemia and conjugated. In unconjugated, the Gilbert syndrome and Crigler-Najjar syndrome are there. And in conjugated hyperbilirubinemia, Dubin-Johnson and Rotas syndromes are there. We will see the overview of these syndrome and we will go in depth of these syndrome intricacy. So let's start. So first, Crigler-Najjar syndrome, it is actually complete absence of UGT1A activity. So this first understand this is the enzyme UDGPT and UDT1A is the gene. So if there is a complete absence of this enzyme, then we will see the severe unconjugated hyperbilirubinemia type 1 and type 2. The decreased activity is seen less than 10% of normal. So this variant is milder compared to type 1 but still results in jaundice. So Gilbert syndrome, in this is polymorphism in UGT1 gene and seen in 5 to 10% of white population and UGT expression by 30%. Just to simplify for you, if UGT1 A1, if gene is 100% absent, you will see Crigler-Najjar type 1. If gene is seen is like 10% activity is seen, Crigler-Najjar type 2, and if its activity is seen in 30% the expression is seen, you will see Gilbert syndrome. So basically, these Crigler-Najjar and Gilbert syndrome are of same spectrum having differential values of this gene activation, that is 100% inactive, 30% and 10%. So these are the classification. We have discussed brief about Crigler-Najjar syndrome. Now we will discuss about Gilbert syndrome. So in Gilbert syndrome, this is seen in actually this is most common hereditary hyperbilirubinemia syndrome. This is very golden statement and this is very important. Which syndrome is most common hereditary hyperbilirubinemia syndrome? It is Gilbert syndrome and polymorphism in UGT1A gene and expression we discussed it is by 30%. What are the clinical features? The important thing this occurs after puberty. So, if after puberty someone gets jaundice, we can think of Gilbert syndrome provided the features. We will discuss them now. So, mild fluctuating unconjugated hyperbilirubinemia 1 to 6 milligram per deciliter, like fasting dehydration can lead to visible jaundice. Okay, a patient is on fast and he was traveling to some deserted area and he developed jaundice and no evidence of liver injury or hemolysis are there. Just think of Gilbert syndrome. It is not that uncommon because this is the most common cause of inherited hyperbilirubinemia. So how we will diagnose? Obviously, we will do genetic testing, and the name is snapback primer genotyping for that particular UGT1A gene. How you will manage? Because this is a mild jaundice, we will not manage this. No treatment is required. If any treatment is required, then like some drug toxicities like episodic jaundice and cancer chemotherapies. which can increase this syndrome severity. Otherwise, no treatment is required. The hero of this chapter is Crigler-Najjar syndrome, as we discussed in brief also. This is due to UGT-A1 deficiency, again 100% and 10% activity. 100% disabled in seen in Crigler-Najjar type 1 and 10% Crigler-Najjar type 2. So this is again, as by definition we can see, this is due to mutation in UGT1A gene. Okay, so this is autosomal recessive, and connecteris is the common complication of this syndrome. So which syndrome of hereditary hyperbilirubinemia has maximum propensity of this connecteris? It is type 1, Crigler-Najjar type 1. Severe jaundice starts in first 3 days of life. Okay, in Gilbert syndrome, jaundice appears after puberty, but in Crigler-Najjar syndrome, jaundice appears in first 3 days. Bilirubin level are can rise up to 25 to 35 milligram per deciliter in first month. These are very huge amount of bilirubin is getting produced by them. Symptom: pale yellow stools. So some people might can confuse with biliary atresia. Persistent jaundice after first week and high risk of connectors if untreated. Okay, so consider Crigler-Najjar when jaundice persists and there is no hemolysis. The hemolysis is not occurring, jaundice is persisting after 3 days with such high level, then you should think Crigler-Najjar syndrome. So how you will diagnose this condition? Bilirubin elevation we know 25 to 30. Higher ranges we will do bile testing. So no bilirubin glucuronide in bile with bilirubin less than 10 milligram per deciliter because enzyme activity is completely absent. So no bilirubin glucuronide in blood bile. This is very much important. Liver biopsy not done nowadays. Genetic testing obviously diagnostic of choice. How you will treat this condition? So bilirubin condition, maintain bilirubin level less than 20 milligram per deciliter. How you will achieve this? The traditional methods like phototherapy, exchange transfusion, and we can give calcium phosphate supplementation because they bind bilirubin in the gut. Again, phenobarbital is not useful in this. Phenobarbital is useful in Crigler-Najjar type 2 syndrome. We'll discuss it later. How you will long-term manage this Crigler-Najjar syndrome? The important thing, just pay attention. The risk of connectors remains even in adulthood, requiring bilirubin level more than 35 milligram per deciliter for damage. Though the threshold is high, but the risks remain there. So phototherapy is required lifelong. Imagine this is very devastating condition as per morbidity concern because you have to give phototherapy whole life, mostly during sleep. Is there any additional treatment for this Crigler-Najjar type 1 syndrome? Cholestyramine agar can be used and avoid triggers also. Liver transplant can be done, but it is not available for all patients. So some people tried hepatocyte transplantation, but this is not very much successful. Alternative therapies like plasmapheresis, metalloprotein therapy can be used, gene therapy can be used. So complication of Crigler-Najjar type 1 syndrome, again cardiac arrest is the important complication because due to very high bilirubin level, this is the main threat, and prognosis is actually cardiac arrest is the main issue in this condition. Liver transplant is cure. So summary, when we will summary Crigler-Najjar type 1, so mutation in UGT1 gene, inheritance is autosomal recessive, onset severe jaundice in first 3 days, bilirubin levels are 25 to 35 milligram in first month, diagnosis absent of glucuronide in bile, liver biopsy genetic test, treatment phototherapy, Long-term management again phototherapy, complication is connectors. So this actually summarizes this syndrome of Crigler-Najjar type 1. We'll again go to Crigler-Najjar type 2. This is partial gluconeoryl transferase deficiency. So we can see it's 10%. So again important missense mutation in UGT1A1 gene. It is due to missense mutation. Just remember missense. And important thing, it responds to phenobarbital because it, or by this way we can differentiate this Crigler-Najjar type 2 syndrome to type 1 syndrome. What are the clinical features? Again, both Crigler-Najjar 1 and 2 presents in first 3 days of life. Bilirubin levels are high but not that high as Crigler-Najjar type 1 syndrome. It ranges from 1.5 to 22. Connecteris is rare. Connecteris is pathognomic of type 1. Normal stool color. Just remember in CN1 the pale stool color was seen because no bilirubin glucuronidation is available. Infant asymptomatic, no sign of hemolysis as seen. Liver functions are normal and normal bilirubin in bile as contrast to Crigler-Najjar type 1. So, phenobarbital response. In phenobarbital, if we will give phenobarbital 5 mg per kg per day, they decrease bilirubin to 2 to 3 mg per deciliter. Treatment is same. We will give phenobarb 5 mg per kg per day to maintain bilirubin level, and lifelong therapy is required. In CN type 1, lifelong phototherapy is required. In CN type 2, lifelong phenobarbital is required. Small risk of connectors, but this is theoretical risk. And oral stat increase fecal fat excretion, decrease bilirubin level by 10%. So this is used in theoretical point of view. So to summarize Crigler-Najjar type 2 syndrome, the missense mutation, that is important, autosomal recessive, we know first 3 days it occurs, and bilirubin levels are 1.5 to 22. Rare connectors, normal stool color, and phenobarbital is required for response checking. Also treatment, and orlistat 10% bilirubin reduction is seen, and mild jaundice, normal life expectancy, phenobarbital is required lifelong. Now we will discuss conjugated hyperbilirubenemias which are inherited. These are actually autosomal recessive, and age of onset. These are actually mild jaundice, usually detected in adolescence or early adulthood, but can occur as early as 2 years of age. Okay, so the factors which can exacerbate them are infections, pregnancy, contraceptive. No morbidity, normal life expectancy is seen, but we will discuss the syndrome. The first syndrome of this category is Dubin-Johnson syndrome. Just remember the gene. Gene is MRP2 and the ABCC2 gene, or defect in this protein MRP2, and gene is this. So this is affecting bilirubin and organic anion secretion. This thing is very important, MRP2 ABCC2 gene. Okay, so as we can see, this is due to defective excretion of conjugated bilirubin. So normal bile excretion and serum bile acid levels are normal. Abnormal urinary corpoporphyrin. So corpoporphyrin 1 increases more than 80%, and corpoporphyrin 3 is decreases less than 25% of total. This is important. This is pathognomic of Dubin-Johnson syndrome. 1 is increases and 3 is decreases. 1 is increases, sorry, 1 is increases and 3 is decreases. So symptoms are abdominal pain and fatigue, jaundice, dark color hepatomegaly, and neonatal presentation is rare. If we do liver biopsy, we can see black pigment in hepatocytes similar to melanin. So this is important. Dubin-Johnson, in Dubin-Johnson, black pigment is seen. Cholangiography and gallbladder X-ray is no abnormal finding. and prognosis is very much excellent. We'll discuss another syndrome that is Rotar syndrome. This is autosomal recessive mutation SLCO1B1, SLCOB3 genes affecting OATP1B and OATP1B transporters. Okay, so the symptoms are similar to Dubin-Johnson. Diagnosis is increased corpoporphyrin 1 and normal corpoporphyrin 3 in urine. So just to remember, corpoporphyrin 1 and 2. It is increased in both and it is increased and normal. Okay, so this decreases and normal in actually Dubin Johnson and Rotar. Okay, so just remember in Dubin-Johnson Rotar syndrome, corpoporphyrin 1 is increased. What is the differentiating factor is corpoporphyrin third, which decreases in Dubin-Johnson but increases or remain normal in Rotar syndrome. Again, another differentiating factor, no black pigment and normal gallbladder in X-ray. As we can see in gallbladder show no abnormal finding in this and this also normal gallbladder. So, we have discussed these syndromes. This is exhaustive looking table, but trust me, this summarizes everything we have read or seen about these syndrome. So, we'll discuss like Gilbert, Krieger-Najjar, 1, 2, Dubin-Johnson, Totar. Just remember the gene UGT1 gene activity. So 1 100% absent and 2 it is 10% activity and Gilbert is 30% activity. Dubin Johnson, the receptor is MRP2 transporter gene, ABCC2 gene, Rotar syndrome, OATP1B, OATP1B3 transporter. So this is genetic cause we have to remember. Inheritance, all these syndromes are autosomal recessive, so no need to remember. Bilirubin elevation, just remember the Kragler-Najjar 1, the severe unconjugated hyperbilirubinemia is there. Onset, just remember first 3 days seen in this Kragler-Najjar syndrome, other are in adolescent or later life period. Phenobarbital response seen in only which condition? This is Kragler-Najjar type 2. And bile analysis, no bilirubin in bile seen in type 1. And urine corpoporphyrin, it is differentiating factor in Dubin-Johnson-Rotar syndrome, increased corpoporphyrin by 80% and decreased corpoporphyrin third in seen Dubin-Johnson and normal corpoporphyrin third seen in Rotar syndrome. Liver biopsy, what is differentiating point? Black pigment seen in this Dubin-Johnson. Gallbladder is actually abnormal in this Dubin-Johnson syndrome and somewhat in CN1. Cholangiography is in abnormal in Dubin-Johnson syndrome. Liver function tests are normal. Prognosis, Kragler-Najjar type 1 is connected as possibility. So this was important topic of inherited hyperbilirubinemia. Hope you will get some insight from this topic. So just go through this video again and you will remember this in good way. So do like, share and subscribe and stay